Okay, folks, in our next segment here, we're going to talk about the notion of being informed. And here's where we want to try to talk about some different models um, of how to share information with patients. So, the first thing we want to talk about in informed consent is that being informed means not simply, as they say, spouting facts or presenting information, but to actually communicate and make sure that the information is understandable. And oftentimes we're going to see that this requires need for continued conversation. And here's where there's a fair amount of complexity and uncertainty. It's one thing to kind of sit down in a calm setting and look through information about a particular condition or procedures. But when you're in the midst of it and not not well, how we come to understand and make decisions can get complicated. So I want to look at the four conflicting criteria that they discussed in the chapter: the patient preference rule, professional custom, prudent person, and subjective substantial disclosure rule. You can always look up the titles of these things, but I'm more interested in trying to look at different models in which information is disclosed. So the patient preference rule is one where the patient's going to dictate what needs to be known. And clearly, your authors do not feel like this is a workable rule. Um, some patients will want a lot of information that they need, can end up wasting time. Others won't want any information. Um, we're going to see that in some of these other models that there are ways that we need to work with patients in presenting information in a digestible way. Maybe at first a patient's simply unable to hear the news. So I understand the reservations with this particular approach, but I think that maybe the authors write it off a little too quickly. I'm not sure it should be a general rule of thumb, but what we're going to see in some of the other models is that we really do have to read where the patient is and what the patient is able to hear. The professional custom rule is where healthcare professionals are telling the patient what is normally or customarily told to patients in similar situations. Whether it's a particular condition or, a particular, let's say, stage of cancer, um, this is kind of the general information that is shared. What the critique of this one is that research indicates that there generally isn't a custom rule, that there aren't standards necessarily because of the unique conditions of each patient and each illness. It's really hard to come up with kind of custom rules that are workable in this way. So the authors feel like this model is not very workable either. The prudent person rule. Here's where the physician's disclosure to the patient should be measured by the patient's need for information material to the decision in refusing or accepting treatment. So we go back to how we understood informed consent. It's really understanding the procedure and understanding the outcome. And so the prudent person rule seems to be focusing on the disclosure that's really needed for that decision to be made. And the authors go through, generally there are 6 items. They added a seventh, which makes sense to me as well. The diagnosis, the nature and purpose of the proposed treatment, known risks and consequences, not getting into too much detail, okay, but within an understandable range, benefits to be expected from the proposed treatment, and the likelihood that the benefits can be realized, alternative treatments that might reasonably be used, prognosis if no treatment is given, and then the condition that your authors include involve costs and particularly amount and duration of pain. So really trying to give all the information even beyond the specific medical so that the patient is aware of roles of insurance and all the possible outcomes. I would just note here that in an ideal setting, certainly we would know possibly the amount of pain or the likelihood of benefits, but sometimes these are particularly gray areas. Um, and so I do think that it's a subjective call in trying to make sure that um, enough known information can be shared without going into lots of debates about the possible different outcomes. The subjective substantial disclosure rule is where healthcare professionals must describe everything that would be material or important to the particular patient and not merely to a fictional or reasonable person. So this is just, for me, this model is simply saying we shouldn't work in generalities, but we need to focus on the patient and condition that's in front of us. And your authors really advocate for a combination of the prudent person and the subjective substantial disclosure, which obviously makes sense to me as well. Note that for this one, there is a demand that you get to know the patient and really determine what is important to him or her. And I just have to think that particularly in nursing, you're probably getting a better sense of that often than physicians who are doing rounds. So this is a pretty important step. I just want to end with noting that we said in the beginning that informed consent is both a legal and ethical obligation. And your text notes that many consent forms that are used for legal purposes really don't provide enough um, information and dialogue to fit these ethical standards. So they use this phrase of these informed consent sign-offs as kind of a blank check, and they don't always have moral or ethical value. So I understand that there are legal procedures, but I think for the purposes of this course, we really want to examine, are they fitting the standard and the ideals that we want to have as best as we're able. Okay, we're going to talk a little bit more about some of the dimensions of informed consent, including paternalism and the role of surrogates.